Waddington. I'm the Director of Mission for St John of God in Ballarat, and I'm going to spend some time with you on ethics and in particular consent in research. As Catholic Health Services, we hold a commitment to the dignity of the human person, to the sanctity of human life, and we have a calling to be the best that we can be for the people in our care. So why research? Why do we do research? Well, good research enables our caregivers, our staff, to offer the best care to people who trust us to act in their best interests. It has the potential to contribute to the development of a compassionate and equitable healthcare system as well. But it's not an easy environment to be in. It's influenced by many things. It's a matrix environment. The National Health and Medical Research Council holds the jurisdiction of law, Catholic Health Australia, and also international influences in that regard with the Code of Ethical Standards. There's the researcher and the clinician, the patient and the participants. So it's quite a complex environment. One of those influencing factors, the National Health and Medical Research Council, the NHMRC, has guidelines around how research is to be conducted. And the first guideline is research must be conducted with merit and integrity, that it must be conducted within a research environment of justice, that there must be beneficence, there must be respect, and that with all of those frameworks, that application is really important, that it's not a mechanical application, that it is context-driven, so it should be, every situation should be considered in the context. What does merit and integrity look like? Well, the NHMRC says that it's justifiable by its potential, that research is justifiable by its potential benefit to knowledge and understanding, to social welfare, and for us as Catholic organisations, what we understand as the common good. That it follows recognised principles of research conduct, that it's conducted honestly, and that the results are disseminated and communicated in a way that permits scrutiny in a timely manner. So, for example, serious adverse events aren't added at the end of a project. They're communicated all along the way, so the project and the consent for the project can be evaluated. So approval is dynamic. In terms of justice and taking into account the scope and objective of the project, the recruitment of participants is essential, that selection, inclusion and exclusion is fair, that there is no unfair burden on the participants, that there's fair distribution and access of benefits, and there's no exploitation of participants. In terms of beneficence, that the likely benefits must justify the risk of harm or discomfort to participants, and that researchers are responsible for research that's designed to minimise harm or risk, that it's clarifying for participants the potential benefits and risks, so that the participants understand that clearly, and that the welfare of the participants is taken into consideration in the research context, and that they hold the responsibility for that. Where the risks are no longer justified, and it's deemed they're no longer justified, the research must be suspended to allow time to consider discontinuation or modification, and then the review body must be notified promptly. The Human Research Ethics Committee membership diversification really assists in arriving at a balanced view. So what is harm, what is fair, and what is benefit? They're difficult questions to answer, and having diversity around the table, I think, helps bring a better understanding. Respect for human beings is a recognition of the human being's intrinsic value, and that's as defined by the NHMRC. For us, it's our understanding of people, human beings, as made in the image of God. They are suggesting due regard for welfare, benefits, perceptions, customs, wants, needs and cultural heritage, that privacy, confidentiality and cultural sensitivities are observed, respect for the participants' capacity, the ability to acquire and retain knowledge, to make choices, and if there's diminished capacity, empowering people where possible and providing for their protection as necessary. The Code of Ethical Standards covers much the same thing. There's much crossover between the two. It asks that people are always respected, their personal dignity is always respected, that we never pose an unreasonable danger to a person's life, sanity or health. The person must understand the extent of the risks, and it goes on in much a similar vein. But it does add a section on vulnerable participants, and it defines them as perhaps people who are defined as incompetent, older children, people with mild intellectual impairment, people who are highly dependent on healthcare, the poor, and people who are institutionalised. So they're asking for a special consideration for them, that there is more stringent requirement to justify the benefits. And also in its consideration of the relationship of the participant to the researcher, that there's not an imbalance in relationship there that might influence somebody to do what they didn't feel like they ought to do. The process, the consent process, what does that look like? How should it look? It should hold due respect for people's capacity to make their own decisions, that it's a choice and that they have choices. It must ensure the protection of the participants. Does the person have enough information to make the decision? Do they fully understand the demands? The end doesn't justify the means. There are some who might argue that it does. So that's a question to be held in consideration. Consent process is not just a formal requirement, that it isn't about a negotiation. It's an objective of a mutual understanding between the researcher and the participant, that an opportunity for questions must be provided, the person is given time to consider, and that they're given an opportunity to liaise with others to seek further understanding. The alternatives to participation must be explained, and what are the consequences? Will my treatment be affected if I don't participate in this? Can I continue just being treated the way I'm currently being treated? How will the research be monitored? What if there's adverse outcomes from the treatment? Who will pay for those treatments? Will I receive care, and will the costs be covered for that? And how privacy and confidentiality will be protected. And the participants' right to withdraw must be notified at the beginning of the project, so that they understand fully. Sometimes it's difficult to withdraw data, and they need to have that understanding before they commence. Who's funding it? Where's the funding come from? What's the intent of the funders? What's their intent of using the information? What influence will they have in the actual process? Reimbursements of costs. Will there be a reimbursement of cost? An important consideration for people in travel and losing time, etc. Details of the dissemination of the results. What are the benefits to me? What are the benefits to the wider community? Will the participants be identified? An important consideration there is the context, because in rural and regional areas, identification is much easier than in metropolitan areas. No person should be subject to coercion or pressure. And we need to be mindful that consent might reflect the deference to the power position of the person seeking participation, and consent, again, must be voluntary. That payment beyond reimbursement could encourage risk-taking, and that's considered ethically unacceptable. A person or institution who has responsibility for somebody who has incapacity to make consent is unable to exercise a lawful authority, but they must make that in the person's best interest, that the capacity to consent also may fluctuate over time or in a conversation. So a person may be lucid and able to make consent at a particular time and not at others. They may not have, people who may not have the capacity to consent, children or young people, people with cognitive impairment, people with intellectual disability, mental illness or substance affected. People may decline to consent. They can say no, and they should be able to say no without having to give any reason, that they simply may not want to participate. The researcher must ensure no disadvantage if somebody wishes to not participate and not explain. Also, the option to withdraw at any stage, and prior to participating, people must be informed of of the potential consequences of withdrawing, consequences in the effect of their data may not be able to be withdrawn if it's a double blind or some other research where it's not able to recall that information. There are occasions of limited disclosure. They're usually applied in circumstances where there is low risk and it's unlikely to affect that. Wherever possible, participants will be notified and sought consent, but sometimes larger studies of larger groups, for example, observation of behaviour in public spaces or in healthcare, for example, the observation of hospital hand washing. Those sorts of projects are done generally with limited disclosure, and because there is low risk, then that is permissible. Sometimes people are given an opt-out approach where they can step out of the research, and it's easier to do that than actually seek consent from every person. But once again, in a low risk circumstance. Sometimes there is a waiver of consent, and only a Human Research Ethics Committee may permit a waiver. That's again in a low risk situation. Generally, sometimes it's if the benefits will justify the risks of not seeking consent, and that can be when it's impracticable to obtain consent. For example, the age of the data, that it's a data where they can no longer able to consent, people may be deceased, the situation occurred a long time ago, but there must always be sufficient protection of privacy. I've got a couple of case studies that I thought I would share with you. The first one is a case study of dementia, where St Elsewhere's aged care facility was approached to be part of a study to further understand dementia in advanced Alzheimer's disease. The study was to go over a 2-year period, and the consent was proposed to be gained from the legal carer of the person because the participants were so advanced in their Alzheimer's that they were deemed unable to consent. The study included the requirement for 4 MRIs, medical resonance imaging, 4 lumbar punctures, 12 blood tests beyond their normal testing, and all of those things would occur at another location other than the participant's usual location. As you well know, I'm sure, that an MRI consists of being placed in a confined space, in a tunnel, it's referred to. The scanner makes a very loud knocking and ringing noise. The whole process requires you to be still at times through a 20 to 45-minute period. And to be successful, it's really important for the participant to know what is happening, to be able to take instruction from the person conducting the MRI. There's also a buzzer for the person to hold so that they can notify the people around them that they're suffering difficulty and that they would like an intervention or would like the intervention to stop. It's quite important that you understand that and that you can use that buzzer because it's your way of communicating. Interestingly, MRIs are marketed as non-invasive. Lumbar punctures were also part of the trial. That consists of taking cerebrospinal fluid from the spine in the lower back through a hollow needle. It takes about 20 to 30 minutes, and there are risks associated that are more common in severe headaches and less common in brain herniation, bleeding and infection. Some cite the process as very painful, others say not at all. But there is a need to lie flat and still for 30 minutes post the procedure to promote clotting to stop further leaking of the spinal fluid. So as you will have gathered, there were some quite serious interventions in that particular trial. What it meant for the carers was, of course, individual, but they were required to manage those situations, to take the people from their current location to the new location and to manage those difficult circumstances as well as their ongoing care for that person. So the Human Research Ethics Committee deemed that whilst the work and the outcome was the potential study outcome was very worthwhile, that the interventions were very burdensome, and they went back to the researcher and asked if they could be minimised in some way. The researcher said the interventions were necessary, but was able to reduce them. So the outcome was the result of a reduction in the MRIs a reduction in the lumbar punctures to 2, a reduction in the blood tests to 6, and the request of the Ethics Committee for clear information for the carers in the patient information consent form of the full nature of the procedures, so that when a carer was consenting to their person that they were caring for to participate in this research, that they fully understood what the interventions were and what that might mean for them. In case study 2, it's in regard to tissue and tissue donation, and it's a situation where Dr. Smith was visiting a physician at a major research hospital. He was visiting Mr. Jones, who was recently admitted. Mr. Jones was ill but was alert and oriented, and Dr. Smith advised him of the need to draw some blood to explore the possibility of infection. And Mr. Jones nodded and said that was fine. While they were conducting that procedure, Dr. Smith mentioned that he had a research trial happening and that they were utilising leftover blood. The project had many researchers and was dedicated to some wonderful causes and studying developing therapies for genetic diseases. They were attempting to build a database to enable the study of population trends and genetic variations. And they would take Mr. Jones' leftover blood and match it with just some basic demographics from his medical record. Dr. Smith gave Mr. Jones the brochure, and he advised also at that time that the tissue that he donated would be used in research spectrums which vary across all disciplines and disease symptoms, as well as yet undetermined projects. He advises that the specimens will be automatically entered into his database unless the opt-out section on the bottom of the brochure was completed and submitted by Mr. Jones. Is that okay? Is that a simple process? There's leftover blood, it's no good to Mr. Jones any longer. It seems fairly simple, except that in Australia, tissue has been not-for-profit and considered part of the not-for-profit system to date. Blood, organ donation, trading tissue at market value was considered to be a commodification of tissue and considered to potentially erode the respect for the human body. It was also considered that altruistic donation was considered part of Australia's social capital. But the genomic significance the genomic significance has seen tissue banks and biobanks proliferating in Australia in the last 10 years. Existing legislation that we have is that's related to tissue harvesting predates commercial opportunities, and changing the legislation and decisions around that are complex because of the reluctance of the world legal system to allow ownership of an individual's body or part thereof. So the NHMRC has said there should be no trade of human tissue for research purposes, but we're not clear around whether this applies to tissue product. And for example, in New South Wales, a block of human tissue is not subject to consent. Tissue is placed in formalin and then set in paraffin, and it's considered a tissue product, not tissue, and the laws apply quite differently to that in New South Wales in particular. That changes what is allowable to that tissue, even though that tissue may still, and probably does, still identify its donor. Genomic significance in human tissue has changed the donation of human tissue. Tissue is now formative of that person's body. It has personal identity, and it contains information or implies information that would normally be private, like paternalism, maternalism, disease, potential for disease. So our understanding of that situation was that Dr. Smith needed to obtain informed consent from Mr. Jones. He needed to give him the opportunity to understand the true significance of donating his tissue, that it wasn't just a little bit of leftover blood, that there was a whole lot more that could mean to him, and he needed to understand that before he consented, rather than having an opt-out approach. So in closing, informed consent requires us to make sure that a person truly understands to what they're consenting, or that the person who's acting on a person's behalf truly understands that it's voluntary and it's not subject to influence, the multi influences that we've made reference to in the last 20 minutes, that a person should be able to opt out any time without disadvantage, that they have time to consider, and that time might not be present time, it might be time to go away, and that's critical that they have that time without to seek advice and without undue influence in their environment. It is critical to educate and inform our people on the ground so that they have an understanding of ethics. They're the people who work in our environment, and they're the people who can notice the gaps and raise their hand if they have an understanding of what is appropriate and what is applicable. And they're the minders of our ethical practice. Thank you.